Good evening and welcome back to blackdoctor.org. I am your host, Dr. Renee, and tonight we have a really phenomenal guest who has been with us before, Dr. Fenwa Milhouse. Dr. Milhouse is a urologist. And so we will actually go over that again because I know several people are like, what is that? And who goes to that doctor? So we will talk about that. But everyone, I always tell you, please make sure you like and start a watch party so that all your friends and family can get this great information. Tonight, we are specifically covering prostate cancer, which, in case you didn't know, the prostate is an organ in men. So any men in your lives, ladies, take this information for them, but also share it with them. So I hope that you will share it with the different fraternities and, the men's group at the church, all of that great stuff, because this is important information, particularly for Black people. And we'll talk about why that is as well. So Dr. Milhouse, Dr. Fenwa, thank you for joining us this evening.
It's always a pleasure. Thank you for having me, Dr. Renee.
So first I have to say, okay, in case you guys don't know who she is, please check out her Instagram. What is your Instagram?
It's at Dr. Milhouse. So Milhouse is with one L. So at DRMILHOUSE.
As you see on the screen. And also check out her TikTok.
Which is at your favorite urologist.
Okay.
On TikTok, at your favorite urologist. Yeah.
So you guys, I say this because she gives, one, the most entertaining videos and pictures, but two, she's educating you all along the way. She's educating men about their prostate, but she's telling you more about urology as a field and about her job. And so it's really a great place. So please make sure you do follow her. So,
thank you.
Oh, you're welcome. So let's get started right away. Now, first of all, let's start with, what is a urologist?
A urologist is a specialist who deals with the urinary tract. So kidneys, kidney tubes, ureters, those are the kidney tubes basically that connect the kidney to the bladder, urethra, the tube where you pee out of. We also deal with the male reproductive system. So any part of the male reproductive system, it's our territory. That doesn't mean we only see men. It does mean a lot of what we do gears around men, but we also obviously women have urinary tracts, and have urinary tract issues. So we do see men and women. We are a surgical subspecialist, so we can see you in the office. There are some diseases that we treat in the office with medications, or maybe we may do office procedures, but certainly we do a wide range of surgeries to also help our patients.
Awesome. And I don't think I knew that urologists saw women too. I knew gyne. No, I knew gyne urologists did, but I did not know that you did too. So that was new information.
General urologists will see women. Yep.
Okay. Awesome. So prostate cancer, last month was Prostate Cancer Awareness Month for those that did not know. And can you tell us what exactly is the prostate? Because a lot of people mispronounce the word. Let's start with that. Secondly,
it's not prostate. It's not like prostrate. What is it? Do they say prostrate?
Yes.
When you're like,
on the ground, if you're a religious person, you lay prostrate. Yeah. That's something totally different. And actually, in COVID, they're talking about prostrating as far as laying down is helping people with their breathing too.
Oh, okay.
So, but no, we're talking about prostate.
Prostate, yeah.
Yes. And so a lot of men also believe that it's related to their reproductive. So we get into that. What exactly is the prostate?
So the prostate is like a walnut or chestnut sized gland that sits like underneath your bladder and just in front of your rectum, and it's a part of the male reproductive system. It is important. The function of the prostate is it secretes fluid that helps to basically make the sperm thrive. To think of it like it secretes fluid that gives energy and just helps the sperm mature and thrive. So that obviously the goal is that the sperm reaches its destination. So that is the role of the prostate. The prostate is one of the only organs in a man that can continue to grow throughout the rest of his life. I mean, obviously, most of us at some point, after we hit puberty or things don't continue to grow. In fact, they can sometimes regress. The prostate is different in that manner, is that it can continue to grow, and it is a common site of cancer, which hence is why we're talking about this.
Yes. So, so what tests are done? Let's start with that. Because I mean, prostate growing doesn't always mean cancer, does it?
No, it's important that prostate size or growth has nothing to do with cancer. Okay, has nothing to do with cancer. Two separate things. Commonly, patients will come in concerned because somebody said, well, your prostate is enlarged, and they think, oh my God, that means I have cancer. Not the same at all. Two separate things. Prostate enlargement is benign, extremely common. Sometimes we need to treat that just because it can affect how you urinate. But prostate cancer is obviously not benign. It's cancer cells. And it's important too that there are no symptoms of prostate cancer. Okay, so you're going to feel fine until you are really sick. You know, if you develop symptoms from prostate cancer, then the prostate cancer is beyond the prostate. Okay, it is what we call metastatic. So you can't rely on signs. There are no signs. So the symptoms of an enlarged prostate, like difficulty urinating, dribbling, slow stream, that's not at all a sign or way to measure risk of prostate cancer.
That is very important.
Yes.
Because that means, men, that you actually need to go to the doctor for your annual physicals regularly so you can have your prostate checked, because you will never have signs until it's too late.
Correct.
And prostate cancer is something that's treatable, is it not?
It is. Yes. So prostate cancer affects about 1 in 8 men. Okay. So having XY chromosome, genetic men, is a risk factor. Okay. It's one of the most common cancers in men. Now, fortunately, about 1 in 41 men actually die of prostate cancer. So a lot of men will get diagnosed with prostate cancer that is either full out curable, you know, we do something and they never have to deal with it again, or becomes a treatable chronic condition that they end up dying of something else with their prostate cancer. So it is a very treatable cancer, particularly obviously if we get it in the kind of earlier localized stages.
So at what age should men be going to get their prostate exams?
This is a great question. This is the $1 million question, because honestly, there is no like hard and fast answer. So without talking you guys to death, we went from one pendulum to the swinging to the other pendulum. So when PSA was introduced, that is a way to screen for prostate cancer. We'll talk about that in a second. Prostate cancer, I'll just say, when prostate cancer screening was introduced in the late 1980s, early 1990s, we screened everybody. I mean, the screening age was as young as like in the age 40, and we screened men until they died. And what we did was we did lower the death rate of prostate cancer. That is true, because before we had any screening, a man presented with symptoms of prostate cancer. And like we said, when you present with symptoms, it's too late. So screening did save lives. But what it also did, inadvertently, the way we were screening, which was screening just like a ton of men, is that we were over treating patients. So men who didn't really benefit from screening, because treatment of the disease was actually was even more harmful than the actual disease itself. So then we went from one pendulum, to the next, something called the U.S. Preventative Task Force. I might be missing one word, but anyway, they like come up with regulations on screening for certain things, right? Mind you, the people on this task force, the original task force, they did not include a urologist on the task force.
Isn't that the way everything happens in this government? I'm just
Like,
saying.
you would think they just would want one urologist on the task force. But anyway, so they said, I think it was in 2012, they said, okay, prostate cancer screening is just all bad. I'm very much like paraphrasing here, but
Right.
it's like all bad. They gave it a D rating, or it's mostly bad. Give it a D rating. A D rating basically means like, oh, it's worse. Screening is worse than not screening. Well, that was absolutely not the way, we didn't want to go on that side. So the American Urologic Association, which is basically like the association that board certified urologists in the United States and North America are a part of, they, they did not, they spoke out against that decision and said that was like throwing the baby with the bathwater out. We need to be smart. We need to have a discussion with patients. We need to stratify patients. We need to look at the whole patient and not just a number and not just like a cell. So we stratify patients. We know that the peak age is like 60 in the sixth decade. And we know that certain populations are at higher risk, okay? African American men, for instance, men who've had a brother or father who's had prostate cancer. There are certain genetic syndromes that increase your risk. So we definitely want to get on top of those patients and screen them in a timely fashion. We also don't want to keep screening a man till he dies. That, at some point, the benefit of screening outweighs it, because the likelihood that you'll die of prostate cancer starts to diminish after a certain age, because you're going to, something's going to beat that. Again, like we said, a lot of prostate cancers are slow growing, or you don't die from them. So now the consensus is, in an average risk man, that is a man who has no increased risk factors. That means no brother or dad. So it's, when we talk about family history, we really talk about particularly like first degree male relative, brother or father. Like if it's your mom's dad, or
Right.
even if it's your dad's dad, that doesn't increase your risk of prostate cancer as, that significantly. But I think the risk, your brother or your dad increases your risk multiple fold. So that's a big risk factor. Number two, being African American men is a risk factor. The African American men are almost double the risk of being diagnosed with prostate cancer. And certainly certain genetic syndromes, particularly something called the BRCA mutations, which are very commonly, you'll hear them when we talk about breast cancer, but actually BRCA mutations also increase the risk of prostate cancer, particularly the 2 type. So those patients need to get started earlier. So if you're not those people, average risk, generally we say about age 55. Start at age 55 and up until around the age of 70. About the age of 70, that's when we need to start to reevaluate whether we really need to continue to screen a man. Now, a lot of our viewers obviously are African American, so that is not including y'all, okay? You guys are not average risk. I'm sorry to say. Oh, I didn't make the rules. I'm just here to tell you the rules.
You just follow.
Yes, yes. So my brothers out there, you guys are not average risk. You are considered higher risk. And because of that, we would potentially talk to you about screening you sooner than 55. How soon is sooner than 55? That's where it becomes a little bit more individual. Let's say you're a Black man who has no other family history, then I would say no later than age 50, but I wouldn't screen a Black man that has no family history. I would probably start screening him somewhere between the age of 45 and 50. Okay. Certainly if you're African American man who also has a family history, I'm looking at, okay, when did dad have prostate cancer? Or assuming it's your dad or your brother. And I want to start at least 10 years before that. So let's say your dad had prostate cancer at age 53 or something like that, somewhat young, then I'm starting you off at maybe age 40, by age 43. So these are just, it is an individual thing. We weigh in the patient's age, comorbidities, family history, patient goals. I have a discussion with patients. I say, this is what is, I'm laying out on the table. This is what I recommend, but I want to talk to you about the pros and cons and the risk and this and that. And I want them to walk away feeling like they had a say, an educated, being educated, a say, and like, okay, well, what are your goals too?
So my question is, and actually someone else has another, there's like 2 other questions we're going to get
I'm
to.
sure.
But my question is, so when you're talking about screening, so when person has their annual checkup, screening involves the PSA, which you said you will explain that, but PSA and the digital exam, or just the digital exam?
Okay, if you're going to do it's the PSA. So
Okay.
of the two, a PSA is a blood test. A PSA stands for prostate specific antigen. So it is a blood test that looks at a specific antigen that your prostate makes, and the certain level that we look for. So that's a blood test, super easy. It's a non-fasting blood test. That means you can get it done. We generally want patients not to ejaculate within a few days of the test. So we would advise you not to have sex or masturbate, right? Within a couple days. We think it might increase the chance. PSA, you're asking a urologist, don't ever check a PSA if you're hospitalized or you're having a lot of acute urinary pain or symptoms, because it just may be falsely elevated and throw you off. And then the rectal exam is where we do one finger digitally to feel in the rectum, because like I said, the prostate lies in front of the rectum. So you can feel the part of the prostate that is notorious for developing cancer. You can feel that part pretty easily with the rectal exam. Now, of the two, the PSA is the more specific one, is the more sensitive one. It picks up prostate cancer earlier than a rectal exam does typically. A rectal exam can be normal in many cases of prostate cancer. I know there are many providers who stop doing the rectal exam. If you see a urologist, 99 times out of 100, we're going to be doing the rectal exam. That's still a part of our repertoire. But I think it's okay if you see a primary provider that may not always do a rectal exam to screen you, as long as they're doing a PSA.
Okay.
Yeah.
So this is a good question. Can you remove the prostate proactively to prevent the cancer without it affecting libido?
Oh, no, we don't do that. Okay, we don't do that because the risks of just proactively removing it outweigh the benefits. So, removing the prostate, 2 main side effects of removing the prostate is actually doesn't affect the libido. Libido is like the desire. That's like the will, right, or whatever. It can affect the mechanics. Like, okay, I have the desire, but the blood isn't circulating to where it needs to go. So the prostate, around the prostate lies these very invisible, like basically invisible, nearly invisible nerves. And these nerves are really important for getting an erection. And so when we take the prostate out, like we can't see these nerves. We know where they are, so we try to avoid them, but we can't see them. And so there is one of the main risks that you can get after any removal of the prostate for prostate cancer is impotence or erectile dysfunction. Obviously not a like life-threatening detriment, but a huge quality of life issue. Another thing that happens, though less common than erectile dysfunction, is incontinence, where you actually have less control of your urine and you have leakage episodes that occur. Because again, there are nerves and muscle that are close to the prostate that help control and keep you from not leaking on yourself when you're doing certain things. So not a good idea. We don't do prophylactic prostatectomies.
Why Black males? What makes them higher risk?
Another $1 million question. Who was that, Keisha?
Yes.
No, $1 million question, girl. We don't know. To this day, we don't 100% know. And there is lots of research and articles that have looked and tried to see, is it biologic? Is there environmental? Is there systemic factors? I think for sure most of us have come to find out in our consensus that there definitely is some systemic factors, meaning structural, like factors in place that make African American men more prone to either not getting screened the way they should be, not getting treated the way they should be, there's that, and there's environmental factors. We could have a whole session about what is it, social determinants of health, and how it actually affects our health, and so that is bar none, probably a huge factor. But we're trying to also see, is there biological factors, like is there an actual biological thing inside African Americans or African descendants that increases the risk.
And then Robert has a good question. Can you have a high PSA and not be cancer? You
can. Good question. So PSA, again, that's that blood test that we use for screening, is an imperfect test. So it is an imperfect test. It can be abnormal and it can be benign. Men who have large prostates will secrete more PSA. And so it may not be in our little, confined, I think it's 4 or less. We know that PSA increases with age. So in general, older men are going to have a higher PSA. And, you can have just inflammation of your prostate or an infection, and your PSA can be high. That's why we really don't recommend checking your PSA. Like if you have a UTI or urinary tract infection, do not check your PSA, please. It's going to be high. Don't check your PSA if you're hospitalized. It may be high. Having a catheter in that drains your blood, that might increase your PSA at that moment. Like I just said, we tend to tell patients to avoid ejaculation because that may increase the PSA. So there are definitely conditions where it can be high and not cancer.
So you said that some people end up just living with the prostate cancer. So obviously then surgery is not always absolutely necessary for prostate cancer.
Correct. Oh, yes. Oh, correct. Yeah. Surgery is, first of all, not the only option, even if we're considering treatment for prostate cancer. Let's say we have a man who has a prostate cancer that we think definitely needs to be treated. Surgery is one of options that he may be presented. One other option that is commonly utilized is radiation. So we can give radiation to the prostate. There's 2 forms of radiation. There's something called external beam radiation, where kind of what you traditionally think of radiation, where you're like, I don't know how they do it, but sitting someplace and, they deliver radiation to a targeted area. In this case would be your pelvis in your prostate. And then there's something called brachytherapy. Think of it like internal radiation. So instead of you like going in for these sessions where they have to give you radiation from the outside source, we can implant these tiny seeds into your prostate, directly into your prostate, and internally they emit radiation. So the radiation is a common alternative to surgery. Some men, depending on some other options that are less utilized but are out there, cryotherapy. So like freezing the prostate, particularly if it's like a small amount, low grade. There's more like certain like focal therapy that they're trying to adopt, which means, hey, let's do something that treats just the area versus the whole prostate. We're trying to see how that works out. Again, we're trying to minimize risks and side effects while still, treating the disease. And in patients who have potentially more advanced stage of prostate, or certainly patients who have metastatic, meaning outside the prostate, then surgery is not usually the way to go, because at that point we need to treat. The surgery of taking just the prostate isn't going to help if you have disease in your bone, in your, in other parts of your body, liver, lungs, whatever. So you're going to probably need something, which we call it, that goes to all parts of your body. So medications and agents that what we call androgen deprivation therapy. So prostate is a male organ, it grows and responds from male androgens or, testosterone related stuff. And so one way to treat it when it's especially advanced is to wipe out the testosterone, basically like cut off the fuel to the cancer cells.
Okay. So, and so I just want to get back the prostate exam. So once you figure out when you're supposed to start having them, you should have them yearly, correct?
Yes. So again, because our audience is almost, are mostly African American men or Black men, we recommend higher risk men absolutely get yearly screening until a certain age.
Right.
Not forever. Again, that age may be 70. Now, if you're in good shape, and especially if your parents live to be, have a really high life expectancy, then we may push it to 75. I rarely screen anybody beyond 75. I mean, even the best shaped men that I see, I'm like, listen, because what I don't want to do is start poking and prodding on a man who's and treating a man who really ultimately wouldn't have benefited. So yes, yearly. If you are average risk, which is not Black men, you could go every 1 to 2 years.
Okay. So we have a question here. Does smoking affect the prostate?
Probably.
Right. It affects everything.
It affects everything, probably. Yeah. I mean, it's not smoking has been tied more directly to certain cancers, obviously lung. We think about oral cancers, bladder cancer, which we're not talking about bladder cancer, but as a urologist, we do see a lot of bladder cancer. Smoking is bar none the number one risk factor of bladder cancer, kidney cancer. It's not as strongly or directly tied to prostate cancer risk, but it probably does. Releases free radicals that change cell, division. So stop smoking.
Right, exactly. If you've been diagnosed with prostate cancer and doctors say something needs to be done, how do you decide on the right treatment, radiation versus surgery?
Well, first of all, you should hopefully talk to a doctor that you feel comfortable, and you should ask questions. You can, when you see a urologist, they should bring up all the options, and maybe they'll say, well, I recommend this option over that option because of these reasons. Now, let's say you're really thinking, you're really debating, you can also consult with a radiation oncologist. So urologists don't do the radiation, even though we talk about those options with the patients, we don't actually do it. So we may send somebody to have a consult with different specialties. So you may see a urologist, and then we want you to talk to our radiation guy too. And after talking to both us and them, maybe make a decision. You should always ask, what are the pros and what are the cons? Why would you recommend what is it about my disease or my characteristics that make you recommend a certain option over the other? Because again, when we think about treatment options, just like when we think about screening, we want to think about the patient. Note, it's not one box fits all, okay? A young, healthy 52-year-old man diagnosed with prostate cancer that's, moderately aggressive, we're probably going to try to do the most definitive thing that we want to do, because that man is young, has at least probably 25 plus year life expectancy. We don't want to shortchange him. So that person is probably much more likely to get recommended to do surgery than, let's say, somebody fast forward who's 70, who just got 72, just got diagnosed with prostate cancer. Probably less likely to get recommended surgery in that instance. So that's just one example.
Does low testosterone affect the prostate?
So this is another part of prostate health, if you will, that we don't 100% understand. We do not believe that testosterone increases the risk either way of prostate cancer. Although I would say, honestly, the jury may still be a little bit out, but we don't believe that. The evidence just isn't really showing that. And we don't believe that low testosterone also is a detriment, particularly to your prostate or your risk of prostate cancer.
So
Prostate cancer treatment, depending on the treatment, you may experience low testosterone as a byproduct of that. Particularly if you're getting treated with like medications for prostate cancer.
So just like we've had several things here where we're like, we don't know, this is where clinical trials are very important. So clinical trials are when people volunteer. They either take medication or placebo. They don't know what they're getting, and they try to figure out why it is and how things work in their bodies. So it seems like to me that I'm sure there's probably some sort of studies going on somewhere to try and figure out why is it that Black men more than have a higher risk.
Yes.
It might, granted, obviously there's all the lovely health disparities in our community. Yes. And lack of health care and all this stuff we definitely are very well aware of. But there could be, as you said, a biological reason. And some people will allow people to, investigate them and try to figure out why is this happening. Especially if you and then your son and then your grandson and then if all of those people end up with prostate cancer, I probably would be very interested to figure out what's going on.
What's going on? Yeah. Yeah. Speaking of clinical trials, absolutely. This is why we practice evidence-based medicine in medicine. We need the evidence. We need trials. We want to have a diverse population in our trials. And one of the biggest hangups with a lot of these trials for prostate cancer is it's not a diverse population. It's Caucasian men. It's in general in medicine, it is harder to recruit African-American patients in trials because we understandably don't trust.
Very, very understandably.
No, you want to experiment on me? Oh no. I remember Tuskegee, y'all, you know what I'm saying? I mean, listen, the medicine has no one to blame but themselves. Healthcare is there's fault. Exactly. Tuskegee is one example. Okay.
There's Henrietta Lacks. There's all sorts of examples.
All sorts of things. So admittedly, we're trying to apologize and do over for that. But that is one of the limitations is enrolling. We do need these studies that have African-American patients so we can be able to tell the difference.
Our bodies are not the same. Just clearly, she already said there's a higher risk for Black men. When you go to breast cancer, there's types of breast cancer that are more common in Black
women.
I mean, the list goes on and on and on. So for that reason, we do have to participate in clinical trials. The key is to have a physician that you trust and speaking to that person. And I will say in the midst of the pandemic, I know Morehouse School of Medicine is doing a whole lot with COVID vaccines and trials. And so I would probably, if I lived in Atlanta, I would be more than happy to help them because I trust them. They look like me. They're looking out for me. Whereas if someone else asked me, I probably wouldn't be jumping on the bandwagon so quickly. Yeah. But if you trust the people, and you have a relationship and you trust the people that are asking you if you'd be interested, please, they'll pay you, one, if that's not a perk, but paying you is a perk, I think. And two, you could be helping the greater good because it would be horrible, especially in COVID, if we get a vaccine next year and no Black people have been tested. So then we try and use it and it either kills us or doesn't work. I mean, that would just be the worst thing ever. So please, we do encourage everyone.
We need it.
We need it. So let's encourage people to please, if you are asked by a trusted medical professional, consider it. Consider it. And if you're of good health, consider it. Someone asked if your grandfather has prostate cancer, are you more likely to get it? Denise, we already discussed that. Actually, the grandfather, it would be the father of that. It would be the son of the grandfather, not the grandson.
Correct.
So it's first degree relatives. So it would be father and brother, not going back that far, not uncles and all of that.
Correct.
Someone else, this is a good question. I think I know the answer, but I think it's a good question. If a person has prostate cancer, should that person see a urologist or oncologist?
In most cases, you're going to see a urologist. An oncologist is not going to, an oncologist gets called in to usually for more aggressive, like advanced disease. Like if your prostate cancer is outside of your prostate, it has metastasized to other places, then we recruit oncology. Okay, but fortunately, 90% of prostate cancers diagnosed in the advent of screening are non-metastatic. Okay, before we started screening back in the 1980s and before, it was a lot of prostate cancers were diagnosed when they were metastatic because we diagnosed them after patients had symptoms. But most of the time, if you're being screened and then diagnosed, it's most likely you're not having metastatic disease, and therefore you're going to see a urologist and maybe never see an oncologist, hopefully.
Are there any proven supplements to keep the prostate healthy?
Unfortunately, there are no proven supplements, and there have been studies to look at supplements. I'm blanking on the one that was really popular. Excuse me, guys. I have a head cold, so I'm just going to blame it on that. I'm having a blame, but they've looked at supplements, and we have not found in evidence and clinical trials that there's been a supplement that has been proven. But that doesn't stop supplements from being out there on the market and selling it to you all. You know what I'm saying? Super beta prostate, this and blah, blah, blah. I mean, cool. I tell my patients, I don't poo-poo, what their choices are. I just say, listen, there is no evidence necessarily that this has been shown to do anything. So as of yet.
So basically, just try to stay healthy. And hopefully,
and see your doctor regularly.
And that's the key, because as we've said, there are no signs or symptoms until it's too late. So you want to make sure that you are getting those annual checkups, because besides your prostate, you need to have all your numbers. You need to know your blood pressure, your cholesterol, your sugar. You need to know all these things so that we can make sure that you stay healthy, because like we've said, unfortunately, Black people are the top of the list of a whole lot of things. And if COVID brought nothing out, it brought that to the light, to understand 100%. That, we have a higher risk, diabetes, hypertension, obesity, all these things, like I said, and prostate cancer and breast cancer. So please go to the doctor regularly. I mean, if you have to go to the clinic, go somewhere and see somebody regularly, get these tests done so that you can know, you can go to bed knowing that, okay, I got that done this year. I'm good. And you can go up, because the one thing, because there's no signs and symptoms, can you imagine just walking around and you have no idea?
You have no idea. You're like a ticking time bomb. Yes. This is not related to prostate cancer, but this cannot be understated. You must get a regular physician. And I'm talking to people, young people too, in your 30s. You need to have a regular physician. So I would see young men, and they would come in because they have erectile dysfunction. And I'm like, okay, do you have any medical problems? Nope, don't have any medical problems. Well, do you see a medical doctor? Oh, well, no, I haven't seen a medical doctor. Well, then we don't know if you have medical problems. You actually might. And then I go to check their blood pressure. I remember one patient in particular, blood pressure was like 200 and something over 100 and something. And I had to sit him down, have a come to Jesus moment and say, oh my God, you are at risk of having a stroke. Your kidneys are at risk of failing. You could have a heart attack, all these things. He came to me for his erections. He was quite perturbed because I shifted focus on the rest of it. Like, you need to really get this taken care of. I've diagnosed young men with diabetes unbeknownst to them after being seen again for things like erectile dysfunction. So please, my brothers and my sisters, please, let's take care of our health. Let's take care of each other. Let's set examples. Just the wellness check once a year.
Right. So, moms, take care of your sons and remind them once they leave the house that they need to get a doctor and they need to see the doctor regularly. And then after that, then girlfriend, boyfriend, whatever it is, your loved one, your cousins, you all need to, like me, this month is October. This is Breast Cancer Awareness Month. I've probably told more than I could even think of friends of mine, did you get your boobs checked? Did you get your boobs checked? Simple conversation. Did you get your boobs checked? Because this is something else that, breast cancer does not cause you to cough or anything. It just could be growing and you have no idea it's in there growing. So it's important for us. This is what we have to do. So men, like I said, your brothers, out on the basketball court. Hey man, have you had your yearly physical? Something like that. Just please. It's very, 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 very important. And we don't want to bury people early. So we want you to be around. And it's great that he went to a doctor because he had erectile dysfunction, but
they'll come for that. Right. They'll come to the doctor for that.
Right. But look, remember in Color Purple, how'd he die? On top of me. Exactly. Yeah. Your blood pressure is 200 over 100, sir. You shouldn't get too excited.
Yeah, exactly.
Right? I mean, come on. So it's really, really, really important. Very important. Men, please, 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 let's, June is Men's Health Awareness Month, but every month of the year, we need to think about our health, our total health. And so prostate just needs to be one of those things that you make sure your doctor checks. When you go for your annual physical, make sure either they give you a PSA blood test or you said PSA, at least a PSA. It could be a PSA and the rectal, but at least the PSA.
Now, obviously, if you're in your 30s, don't be checking a PSA in somebody's, I get annoyed when people do that. But yes, really talk to your doctor about when when to be screening. You can ask your primary doctor, like, hey, I want to know, should I be screened? And if they don't know, they'll send you to see a urologist like me.
Exactly.
I've had consults just for that, just to talk to men about what the pros and cons on screening them. So,
and this is the other reason why family history is so important and why we need to have these discussions, because like she said, if your father had it at say 53, then you definitely need to start thinking about being screened at 40 so that you don't end up having it as well, or at least they can find it early. So this is why family history is so important. And if you say, well, I don't know my father, he's dead, whatever, this is the other reason why you need to go to the doctor regularly. And then you probably do need to see a urologist so that you can stay on top of these things and you can start, for your family, start that family history. Because yes, there's adoption. There's all sorts of things that can happen where you may not know your family history, but you can see why it's so important. Colon cancer is another one that is very treatable and curable, but you have to find it early. And that's another one. If your parents, father or mother, had colon cancer at 40, that means that you need to start having colonoscopies at 30.
Yes.
And I did have somebody who told me that their mother did get colon cancer, I think at 40 or 35. And
they need to have a colonoscopy at 25.
They had to start having colonoscopies that early. But this is why family history is so important, because colon cancer is something that can be treated. We just have to find it in time. Yeah. And so that's why you have to you have to stay up on these things. And this is why it's so important that you give the doctor complete history and say, I have this, I'm taking this medicine. Make sure you put all that information in your phone. And so, because usually we always have our phones, and pull it out and you can tell them the information. It is the worst thing. I actually did an article for Essence. They asked what is the best thing that patients can do for a doctor? And I was like, make sure you have all that stuff already written down.
Exactly.
Bring it with
That's so helpful.
Have your questions already too. So then you're great. You have everything. The doctor knows everything. Because the worst thing, and I hear this story way too many times. So do you have any health conditions? No, I don't. Okay, but do you take medication? Yeah, I take such and such and such. Okay, so wait a minute. So you take that's a blood pressure medicine. So you have hypertension. Oh, I do? Like, those little things, And
I posted that on my Instagram.
Okay, so I'm, like I said,
you're not alone.
I've heard this a million times, you guys. And especially in COVID, people were like, oh, well, they got COVID and da-da-da-da-da. Well, did they have any of the comorbidities or underlying conditions? No. they were hypertensive and I was like, come on. Yes.
Yeah.
And so the crazy thing is I was literally on a webinar about COVID with a patient and she was like, you know, they asked me, did I have any underlying conditions? I told them no. That woman had hypertension and diabetes. I think she didn't know that those were conditions.
Yes.
So, you know, sometimes maybe your doctor didn't explain things well, because that can happen.
That can happen.
Or sometimes you just miss something in translation. So please make sure you understand what medicines you're taking and why you're taking them, so that if you go to another physician, they can understand the complete picture.
Correct.
So, so because, you know, this lady was on something, you know, she's already on medications for, so when they, you know, treat her for COVID, they need to take this into consideration. And so this is why it's very important. But please, you know, there's no reason not to, I understand there's adoption and all this stuff, but there's no reason for you not to get treated. You know, you need to go to the doctor and you need to talk to the doctor and figure out, okay, well, this is why I don't know this. You know, how can I start, you know, my own history and, you know, start from the beginning. So, thank you everyone for tuning in this evening. I hope you've picked up on something, and I hope that we will at least have conversations with the men in our lives, or the people that were born. We have, you know, transgender people now. So people who are born with genetic male XY chromosome, have conversations with them, because you could be transgendered, still have a prostate, correct?
Yes, and still need to be screened.
And still need to be screened. So please, please, let's, you know, because we don't need to lose any more men young.
Yes.
You know, and if we can do something, this is something that's simple. It's not, it can be found. It can be
really not a big deal.
It's not terminal. Let's, you know, let's do something about it ahead of time. And as she has mentioned, and I want to keep emphasizing, there's no signs and symptoms. Please go to the doctor and be checked regularly. Please go get checked regularly, because by the time you have a problem, you really do have a problem.
And we don't bite. We don't bite.
Look how cute she is, you know? You guys, please follow her at Dr. Milhouse on Instagram. And your favorite, you said? Yep. Your favorite urologist on TikTok. Those are her two platforms. I'm telling you, you guys, you'll be very entertained. and
thank you.
You'll be informed. I'm telling you, she gives good information. She even told the story of how she became a urologist. We didn't get into that today, but please check it out. She, like I said, she posts a lot. So check her out. And I appreciate you taking time this evening, because I noticed you were having a little head cold issue. I could tell.
I know, yes.
I could tell. So I really do appreciate it, because I know that this is a lot.
Anything for you, baby girl. Anything. Thank you so much.
I appreciate it. So thank you, everyone. And I will see you. Actually, I'll see you tomorrow. We're talking about diabetes tomorrow with Dr. Kelly. So diabetes is men and women. So bring it on, everyone. Bring your questions. We're going to talk about diabetes. Dr. Kelly is amazing, and she's been on before, but she has a whole program to help you if you have type 2 to hopefully get off of insulin. So you know you want to tune in. Have a good